Thanks, Jamie, for the introduction. I'm also very pleased to announce that I have finished my term. I finished my term last year as president of CNSA in November, so I can focus more on my research now. Today, it gives me great pleasure to share with you some of the work that I've been collaborating with the YCS Queensland over the past few years. And indeed, instead of sort of generating new knowledge, conducting primary research, it is really a quality improvement implementation type of study that we have conducted, and it is really around the interventions that the YCS Youth Cancer Services Queensland has implemented over the past few years, led by the team led by Rosalind Henny, who is in audience today. It feels like yesterday that the AYA fertility preservation guidelines came out, but indeed it is 4-year-old now. But what I really like about it, I think it really articulates the problem really well. Many young people report feeling that they were not or were inadequately advised of the risk of their options to preserve fertility. The decision about whether to pursue preservation or not was made for them. They were not given enough time to discuss concerns, and they did not fully understand the ramification of their decision. A few years ago, the YCS conducted an education needs survey with nursing staff, medical staff, and allied health staff. And if you can see here on the right, that gives you sort of the distribution of people who answer surveys. And that's really quite standard in a lot of surveys that we conduct with health professionals. But what I want to highlight to you, though, is showing up on my screen. It's this red box here about how confident clinicians really are in discussing about fertility options. And don't you love traffic lights? Because it just really tells you that that is the area that people were the least confident in. And tomorrow, I hope that I can share with you some of the data that we have from the STEP study, that we actually do see that people have different levels of confidence depending on the discipline that you come from. But based on that as well, that YCS actually conducted a pre-test, post-test type of quality improvement study looking at the effects of bundled interventions for the group of patients who were aged 14 to 25, people who were newly diagnosed between 2012 to 14, which is pre-intervention, as well as 2015 to 16, which is post-presentation. We got the data. From for the pre-test, we got the data from medical records. For the post-test, we actually got it from a clinical database that we have statewide, which actually gives us a little bit of problem, but I'm going to acknowledge that as a limitation later on, and you would understand it a little bit more in terms of how we collected that data. But we collected data on patient demographics, age diagnosis, and treatment received. We also looked at, and these are the three major outcomes that we were looking at, which are documented evidence of risk of infertility, discussion, documented referral to a fertility specialist. So it was interesting to see from the last talk that people actually it is absolutely something that patients appreciate, and also documented evidence of fertility preservation. So YCS covers the entire state, but for this exercise we covered the major cancer centers, which include 3 tertiary metro hospitals and 2 tertiary regional hospitals. So what the bundle intervention is really about, first of all, YCS developed 3 quality indicators, which are prospectively collected from the clinicians at the 5 sites for all patients that were referred to YCS. So the 3 questions were, was the patient provided with written and verbal information regarding risk of fertility preservation and risk of infertility and fertility preservation options? Was the patient referred to a specialist, and did fertility specialist And did the patient undergo preservation, and if yes, what method? In terms of targeted education, there were a lot of multiple in-services that were happening across the state, but there were also two times in the intervention phase whereby the YCS got a fertility specialist to address the medical and nursing and allied health staff in two sessions, but these sessions were then streamed to the state as well. In terms of patient resources, the YCS developed gender-specific information packs, and this was an initiative that was based on the feedback that was provided in the education need survey. And finally, there were also referral pathways that were developed, which includes a referral form. And prior to that in Queensland, a referral was done more so through medical letters or even a phone call to a specialist. But at that point of time, then the YCS actually developed some referral tools, which include information that the fertility specialists would really want. For example, whether they had history of HIV or Hep B, Hep C, and the serology results as well. So if you look at our pre and post-intervention demographics, they are really quite similar, and we have around 260 in the pre-phase and 216 in the post-phase. We actually we were able to observe a significant improvement in all three outcomes that we were looking at, including the evidence of discussion, the documented referrals, as well as documented outcomes of fertility preservation. This graph, we thought it would be interesting for us to show because we actually see the increase of counts. This is not percentage, this is of counts, because some of our patients were able to have more than one preservation methods. But what you can see there is that we were able to demonstrate an improvement overall, but as you can see in the 2015 and 16, you can also see even for male is also increased in the post phase. So this is around documented discussion. Other than to say that there are improvements basically throughout for all these groups that we are looking at. For the lymphoma group, we saw that they were already having quite a high percentage of people who had documented discussion already, so we were not able to see a significant, statistically significant difference per se, but as you can see, the pre-phase, we were already having 80% of them having documented discussion about infertility and options. Sorry. This is around documented outcomes, and once again, we actually see that we were not able to demonstrate an improvement in the leukemia group and the brain cancer group and the soft tissue sarcoma group, but everyone else. Now with the brain cancer and the soft tissue sarcoma group, they were sort of relatively smaller numbers, but with the leukemia group, we were not able to see a lot of improvements at all, although we actually seen that the majority of their patients have had that discussions. When we just look at the post phase and just to look at the factors that are associated with having documented preservation outcomes or not, we still can see a disparity between younger and older patients, with the older patients having more documented outcomes than the younger patients, and also having male more documented outcomes. So this disparity, we actually can still see that in our post-phase. And I haven't shown our pre-phase outcomes here, but in the pre-phase, we actually saw more disparities between diagnosis groups. So we actually do think that our interventions have closed the gap somewhat by closing the gap of disparities for some of the diagnostic groups, although we are still seeing the disparities in between genders and age group. So this study demonstrated improvement in the pre-phase and post-phase in terms of the three outcomes that we looked at. The disparities between gender and disease groups were closed to a certain extent, but as you can see, it's not completely closed for reasons that we can appreciate. But then I still believe that there is room to improve, regardless of whether it's for male or female, whether it's younger or older AYA patients. We were not able to demonstrate improvements in documented referrals to specialists and outcomes of fertility preservation in leukemia patients. We are not too certain why this is, other than the acuity potentially, but it certainly deserves some further discussions and exploration. Further work can examine the effects of regular feedback. Now, the quality indicators that that YCS developed is reported to the services every 3 months through the steering committee, which are really the executives of these major centres. But what YCS hasn't quite done yet is to feed them back to the clinicians who are not necessarily having a specific profile portfolio to look after AYA patients. So given the implementation science literature is telling us that regular feedback could potentially change behaviours, it's certainly worthwhile for us to look at feeding these outcomes back to clinicians at a clinician level rather than just feeding it back to the executives and see whether that would make a difference to see further improvement. This study has also provided a baseline, I guess, for Queensland, but also benchmark for us for future comparison. Due to the retrospective nature of the pre-intervention cohort data, it is indeed a flaw or a limitation for us, because in the post phase we actually got the data prospectively from the services. So that is one limitation that we have. The second limitation that we have is that for the pre-phase and post phase we actually used a different data collection method. Having said that, we do think that now this data can form the basis for future data collection. Then we can actually keep our data collection method consistent using the quality indicators. Nevertheless, we think that documentation is extremely important in our practices. And failure to document can impede future clinical intervention, and sometime down the track, if a psychologist or a social worker or a nurse picking up the chart trying to sort of establish what has been discussed or not, basically we just can't do that if it is not documented. And of course, there are also potentially medical legal consequences, and as we know that there are probably already case studies that is out there. And finally, we would just like to acknowledge the team who has put in all these efforts supporting this few year worth of work. Thank you.
Thank you so much. We have time for about 1 or 2 questions, if anyone has anything.
Congratulations on your study, Raymond. This may be a silly question. I understand the study was 14 to 25-year-olds. When do you actually first consider fertility in any young child, or is it only at 14 that it started to be considered?
Can I please refer this question to Jeremy? I think Jeremy will be best placed to answer.
Yeah. I mean, it's a very interesting question. I don't think there's any specific number that we use as a guideline for consideration of fertility preservation and the discussions that occurs around, especially in our paediatric population. I mean, I'm not a paediatric oncologist myself, but there certainly are some guidelines that are being created and exist within frameworks looking at specific discussions that go around the younger child. But essentially, there is no specific age that's a barrier currently. I guess one of my follow-up questions was on the other side in terms of what do we do with our 25 to 50-year-old patients, and how do we address some of those discussions? So I'll be interested to see what sort of improvements there are with regards to those sorts of discussions.
I don't know if I have the answer, but I do wonder whether some of the initiatives that we have in the AYA space, I do wonder sometimes whether they should be AYA specific. So I think a lot of the capacity building activities, education targeted targeted interventions like referral standardization or what have you, I actually believe that it should apply throughout. And depending on what state or what country you are in, I just don't really think that age group definition is really that much of a key consideration for us. And indeed, I actually think that we have a lot of room for improvement, not just in the AYA space. I actually think that we need to consider our whole service as a whole. Having said that, our AYA group, we do have some dedicated resources, such as funding or what have you. I do think that if we are to do something, I think that is the place for us to start, and then we can actually see how that can benefit the older patients as well, that in other countries that they also define as AYAs.
All right, many thank you. That's done.